So you're going to get to hear from me twice today. So we're going to talk first about understanding Parkinson's disease and just talking about some of the symptoms and what we know about it and what we don't know about it. And then we're going to talk separately about the treatments. And we have a little bit of time built in for questions. So if you have any, feel free to jot them down so that when the time comes, you'll be able to just raise your hand and someone will come and help you deliver those to us. So our goal is to talk today a little bit about the motor symptoms of Parkinson's, the non-motor symptoms, and also how we separate it from stuff that kind of looks a whole lot like Parkinson's but isn't Parkinson's. So this is a very common condition. The reason this room is filled even more than we were initially expecting is because there are millions of people in the world with Parkinson's. Millions of people, so 4 to 6 million, and that's just a guess. Imagine how many people aren't diagnosed or don't go to a doctor. So that's an estimate. If you make it to 60 years old, you got a 1 in 100 chance of getting it. So I see some people in the room who may be 60 or more. You have a good odds. And the longer you live, your odds go up and up and up. So it's a very common condition. By 2030, it's expected that we'll have twice as many people with Parkinson's. So we'll need a bigger room for this meeting in 2030. The main 4 motor symptoms that are being diagnosed with Parkinson's include tremor, shaking, rigidity or stiffness, akinesia or bradykinesia. That means lack of movement or slowness of movement. And postural instability, meaning balance trouble and walking changes. So the first 4 letters are trap, and sometimes people can feel like they're trapped in their body. It's hard to move. And sometimes the tremor is a movement we don't want to have. So early on, when people are first diagnosed with Parkinson's, or maybe even before they're diagnosed, they might experience more subtle changes than a tremor that's outwardly obvious. Some people may notice their handwriting becoming smaller or shakier. Some people may notice they feel stiff on one side. And a lot of times people have been through 2 or 3 different specialists getting diagnosed with other stuff before they recognize it's actually Parkinson's. I can't tell you how many times somebody was told, oh, you have a frozen shoulder. Oh, it must be a rotator cuff injury because their arm wasn't moving. I bet if I surveyed, at least one person in the room was told something like that before they actually found the true diagnosis. The other problem can be one arm not swinging like the other or one leg not keeping up with the other when walking. Some people might experience more subtle things like cramping of the legs or the feet, and fine dexterity troubles like buttoning, women's fastening their bras or putting on their earrings might notice trouble doing things with their hands. And changes in the facial expression or the speech. Sometimes it can look like someone's less expressive, or they may look like they have less emotion, but they don't have less emotion. It's just less outwardly apparent. Some people will call that a poker face. And the speech can become softer or trail off the longer someone speaks. With time, people may experience changes in the way that they walk. They may experience shorter steps or shuffling steps, more difficulty with transitions, say from one room to another, going through a doorway, or turning in the bathroom or an elevator. People might experience stooping of the posture that is difficult to control. A lot of times someone says, well, just stand straighter, but it can be challenging to do that. Freezing of gait is a problem where it's a difficulty with initiating gait. It's a problem getting going. It's like an ignition problem. People want to move and their feet may be stuck, and it will be hard to take the first step. Sometimes when people experience that, there are outside cues that can be helpful, like someone saying, take a big step, or pretend there's a line and you're stepping over it, and that can help break that problem. Not everybody gets every symptom that I talk about today, but these are things that some people may experience. With time, some people may experience something called dystonia. Dystonia is an involuntary muscle contraction that the brain is making the muscle squeeze when they're not supposed to squeeze. And people can experience twisting or pulling as a result. The most common ones would be excessive blinking that we call blepharospasm, tilting of the neck that we call torticollis or cervical dystonia, or curling of the toes that we call foot dystonia. People often experience that as their medicine wears off, so it would be common to have that overnight or in the early morning. Dyskinesia is a problem of excessive movement that typically occurs at the peak of a medicine effect. So with time, we'll talk about this in the management portion, but with time people can experience it when the medicine is at its peak. They develop involuntary movement that can be uncontrollable. For most people, that is preferable to feeling frozen and stiff because it is at least the ability to move. So some of these things occur earlier and some of them occur after having Parkinson's for some time. And the dyskinesias and the wearing off and fluctuations may occur after time. Some people will take their medicine and they never notice a difference, that it wears off. They kind of feel the same all day long. And other people, as they rely more on the medicine, may experience that before the next dose is due, the effects wear off, and that's what we call wearing off. When we talk about motor fluctuations, we mean going up and down between the medicine working and not working, working and not working. And those are difficulties that some people may experience. I'll talk about this slide more when we talk about medicines. So the tremor and the walking, most people think if you have Parkinson's, that just means you have a tremor or you shake. And if you don't shake, they don't think you have Parkinson's. And that's not true at all. Actually, not everybody gets a tremor. And the tremor is just one small little aspect of Parkinson's. Probably anyone who's had it long enough may say, if you only understand tremor, you don't understand what I'm going through. So this is actually me on the top of that iceberg in Alaska climbing that glacier that you see. Okay, so non-motor symptoms actually are a whole big pool of things that may occur, do not occur to each individual, but when they do, they can be even more of a problem than the tremor or the walking. These are so common that in one survey, more than 98.5% of people with Parkinson's had at least one of them. And these may be more stressful for a care partner, like a spouse or a significant other, than actually the tremor or walking problems. So let's talk about some of these. And I feel like most people know about the walking and the tremor, so we'll spend a little more time on these other more subtle things that not everyone may be aware of. One of the often first symptoms of Parkinson's can be the loss of the sense of smell. So people can notice that food doesn't taste as good, or that they just can't smell things like they used to. And this is kind of a mystery that's sort of being looked at as, could this be a clue? Where does Parkinson's start? How do we get Parkinson's that it first would affect the sense of smell and travel to other areas of the brain that do even more important things? People can have funny feelings in their legs. Most often those are associated with an urge to move them or shake them or rub them. And people could experience visual hallucinations. One interesting study recently was saying, how can we pick up on Parkinson's sooner? One day when we have a cure or when we have a medicine that actually will change the future of a person's Parkinson's, instead of just treat the symptoms, we're going to want to spot it as soon as we possibly can. How can we figure out you've got it before you have tremor or walking or anything? So they took a bunch of people with very early Parkinson's, even before they needed a single medicine, and they gave them all kinds of surveys and questionnaires. And basically what interestingly came out is the three things that really helped separate the people with Parkinson's from people of the same age who don't have Parkinson's were the loss of the sense of smell, constipation, and a sleep disorder where people move in their dreams that we'll talk about in a second. So people who had those three things were more likely to be someone with Parkinson's compared to not. Now, of course, not everyone who has those symptoms develops Parkinson's, but it's very interesting that those might be clues to what's going on. People can experience problems with their digestive system. The most common is constipation. I won't make you raise your hand if you experience that, but I bet if I did, there'd be a lot of hands in the air. Probably one of the most common symptoms that people experience and one of the most aggravating. People can experience drooling. We call that sialorrhea, drooling. And we think it's because people don't swallow as fast or as frequently as you normally do without even thinking about it. You don't make more saliva, it's just if you don't swallow it the way we normally do, then it can accumulate. In some people, like we said, constipation. People can experience a lot of different sleep problems with Parkinson's. And again, if I had people raise their hands, many hands would be in the air. Who has any trouble with sleep? Sometimes it's a problem getting sleep, period, which we call insomnia. Sometimes it can be an issue that when you're sleeping and you think you're asleep, things are going on that are preventing good rest. One of those things can be restless leg syndrome, which is a condition in which a person has this uncomfortable, yucky feeling in their legs that they may have to move and get up and shift positions, and it prevents getting rest. Another is called REM, behavior disorder. REM stands for rapid eye movement. It's a deep part of sleep where we're dreaming, and normally we should be paralyzed. And if we're not paralyzed, when we're fighting or punching or running, we're moving around, and basically it disrupts our rest and the other person in the bed's rest as well. And more often I hear about this from the person who shares the bed, who's getting beat up in the middle of the night. And the person says, I think I sleep just fine, but the next day they're falling asleep all day long. So if you're falling asleep all day long, although you have to look at what are your medicines and are you going to bed with enough time, sometimes you may have a disorder like this that you can talk to your doctor about. It is treatable, which is the good news, but I have all kinds of great stories about what happens in people's sleep. One of my favorite was that the husband was dreaming about playing basketball, and he was trying to pull his wife's head off because it was the basketball he was dreaming about. And she woke up, what are you doing? And you know, people dive off the bed because they're dreaming of swimming. I didn't make those up. Those are real people experience those. So it's actually very interesting. Fatigue. I would probably say fatigue might be the most common and the most aggravating and one of the most challenging to help. But fatigue is just a feeling of a loss of energy and ability to complete the tasks of the day, tiredness sometimes as well. But it's a little bit different from somnolence or sleepiness. Some people are awake, but they just don't have the energy. Okay, mood trouble. Depression is very common in Parkinson's, and it's not only just the obvious, well sure, nobody really wants to have a health condition that's challenging, so that's kind of makes a person depressed. It's not just that, it's not just the reaction, it's actually a physical change in the brain that has to do with neurotransmitters. Just like diabetes is a physical change with people's insulin, this is a physical change in people's serotonin levels, also very treatable. People may experience apathy. Apathy means the loss of motivation or drive. You know, it's a loss of that motivation to actually do what you want to do. You want to do it, but you just, oh, it'll wait. Oh, I'll do it later. Oh, I'm just going to relax a little bit. And you just don't get to stuff. And that can be really challenging because you know what you need to do, and you may know the exercises the physical therapist recommended, but if you don't have the motivation and drive, it's difficult to actually carry them out. Anxiety is also very common. Some people will experience that as their medicine's wearing off, an internal restlessness or anxiety, and some people it could be independent of their dosing intervals. So this is a slide from a National Parkinson Foundation registry study. I bet some people, has anyone in the room participated in the long-term registry where you kind of once a year share your information a little bit? Maybe at least one or two. It's a great study that's looking at thousands of people with Parkinson's just to see what can we learn that we need to be doing better. And so they basically did some surveys to see how often do people have depression and how good are their doctors at discovering it and treating it. And the results are really interesting. It turns out that about 60% of people in Parkinson's have at least symptoms of depression, if not full depression. At least 40% seem to actually have clinical depression. That means if you have a table of 10, then 4 people at the table would be feeling depression that meets criteria to say you have depression. So seeing how common it is, wouldn't you think your doctors would know about it and get it and ask about it and treat it? Well, this is actually reflecting centers of excellence. These are the best places that you can be getting care for Parkinson's, places that take care of hundreds of patients, do research, do education, and achieve a designation by the National Parkinson Foundation as a center of excellence. And this is looking here on the left side of who's getting treated when they actually have serious depression. And each bar is a different center. And you can see that at the best places, in some places only 4 out of 10 people with serious depression are getting treated for it. And even at the best centers, less than 80%. So it's something that you have to be aware of, watching for and talking to your doctor if you think you may be experiencing these symptoms. The autonomic nervous system is the part of our nervous system that just does stuff you don't have to think about. It gets your guts to move when they're supposed to move. It gets your blood pressure to go up or down like it's supposed to. It makes you sweat when you're supposed to sweat, and it regulates stuff. When this gets out of whack, people can experience a problem that when they get up, their blood pressure drops, especially first thing in the morning, and you get that whoa, woozy or dizzy feeling. And this can even make people pass out sometimes. If you experience that, there are things that can be done, and we'll talk about that. Some people could sweat inappropriately to the temperature. Here in Florida, it's usually, there's a good reason to be sweating, but they could sweat when it's not even hot. Constipation we talked about, and sexual dysfunction. In men, they may experience erectile dysfunction even earlier than the typical age that people experience that. And cognitive trouble, that means memory or thinking. The most common thing is trying to think of the word you want to say. And you know, if you know enough people who are in the age range that typically gets Parkinson's, you know that that's pretty common anyway. But it's even more common if you have Parkinson's to have what we call the tip of the tongue problem, where the word is right there, but you just can't get to it. Thinking of a name or a word you want to say, and a little bit slower processing, where it takes a little longer to think of what you want to say or respond to things. This is important for driving, because in driving you have to have a very good reaction time, that you see something, you perceive it, you think about it, you act on it. Like a sudden child runs in front of the car, and to be able to actually push the brake, it takes a little bit longer. Some people could experience more severe memory problems. Not everybody experiences the most severe memory problems, but it's something that has to be monitored. So after hearing all that, if only brains grew on trees, we could actually just replace them. This is actually a real plant that I saw in Aruba that to me looks just like a brain. But there's a saying, when you're a carpenter, everything's a nail. And when you're a neurologist, you see brains everywhere. You see brains in corals, you see brains on plants. So that's how it goes. So Parkinson's most commonly affects older adults. In fact, only 5 or 10% of people have symptoms before age 40, like Michael J. Fox, who recently came back onto the TV scene. Most people experience them after. This whole gray area is people who experience symptoms after 40 years old. So we talked about what does it do to people, how do they look on the outside, how do they feel on the inside? Well, what the heck caused all of this in the first place? And it seems to be very complicated, and the short answer is we still don't know. We're looking and digging, but we still don't know. Don't get too caught up in all the things on this slide. The bottom line is it's a combination of a genetic susceptibility. Your genes may make you prone to it, and some other stuff seems to trigger it. Why do two people in the same family that have some genes in common, one may get it and one may not? There's some sort of outside trigger that seems to possibly trigger the process. What we know is whatever causes it, it may involve oxidative damage. This has to do with cell processes. It may involve these organelles in the body that make energy called mitochondria. It may involve other things. What we know is that it results in abnormal protein accumulation in the brain and in loss of neurons in a particular area of the brain I'll show you called the substantia nigra. These are just some of the genes that can be linked to Parkinson's. And so not everyone who has it has the same genes. You don't have to be able to read it. I just want you to see there's lots of them. It's not just one single answer. And it may be the combination of all the genes that you have that makes you prone to it. And each person at that table might have a different set of genes. And so we still don't know why, but it's exciting every time we find one, because if we find a big group of people in a same family and we test their genes and we say, this is the abnormality they all have in common, then we figure out, well, what happens differently if you have that abnormality? What gene, when that gene changes, what protein is different? And what does that protein do? And so then we learn something about the change. So all of these teach us some little clue. So this is what happens under the microscope. This is actually, the bottom is what we call gross pathology, meaning the cutting through somebody's brainstem. On the left is, if I can make my little arrow, this is called the substantia nigra, this little black area in what we call the brainstem. In Parkinson's, you see it looks less black. Some of the neurons or nerve cells that are in this area called substantia nigra have been lost. Those nerves make a neurotransmitter or brain chemical called dopamine. So this results in basically a deficiency in a brain chemical called dopamine. We know this is a very simplified version, and that's not the whole problem, but that's the part that seems to create a lot of the symptoms. But we know there are changes throughout the brain that go along with this. On the top is what you see if you take a small piece under the microscope and you see this deposit called a Lewy body, because some doctor named Lewy attached his name to his discovery of this little accumulation. We even know what it's made out of. We know it's made out of a protein called alpha-synuclein. And we're still trying to figure out, is this the cause, or is this just a symptom that whatever's going on causes this to occur, but this isn't the cause of the disease? We don't know, but these are all aspects of what we have discovered so far. So that's kind of what's going on below the surface. But on the outside, a lot of different things can look like Parkinson's and even be something different. So for just a little while, I want to talk about some of the mimics, because some people in this room may not have actual Parkinson's disease, but they may have Parkinsonism. That means you got symptoms that you look just like you got Parkinson's, but it's actually something a little bit different. I won't spend lots of time on those, but just so you've heard of the names, in case at any point a doctor says to you, you know, I think this is actually this other thing. In the middle is Parkinson's disease. There's an overlap of symptoms with something called essential tremor, which is usually a familial condition that has tremor, but doesn't tend to cause the same kinds of gait changes, doesn't tend to affect people's memory or other things, all those symptoms we talked about. Some people could have Parkinson's symptoms because of a medicine they took. Usually these are medicines for psychosis or for gastrointestinal problems, but a doctor will ask about what you've been on in the past to see if it could be related. Vascular means stuff due to abnormalities in blood vessels, and specifically we mean strokes. A person who has a whole bunch of strokes over time can develop symptoms that look a whole lot like Parkinson's disease. So occasionally a doctor may get an MRI to make sure that you haven't had a whole bunch of strokes. On the right side, I'm going to talk about these individually because they look a whole lot like Parkinson's. Before I talk about them though, when would you even suspect it could not be Parkinson's? These are the red flags. If you don't get better from levodopa, which is the best medicine, the most effective medicine for Parkinson's, it's not that likely you got Parkinson's. If Parkinson's is a problem where dopamine is deficient and you give someone back dopamine, they should at least have some improvement, at least early on. If people have a lot of hallucinations or a lot of memory problems in the first couple years, it's probably not Parkinson's. Parkinson's is a slowly progressive condition, and in the first few years, we don't tend to see those things. If people are having falls all the time within the first 2 years, it's not likely it's only Parkinson's. It could be a different condition, or it could be Parkinson's aggravated by other things like neuropathy, loss of feeling in the feet, or other conditions. And if people have problems moving their eyes up and down, it may be another condition I'll tell you about. So I don't want you to get too hung up on these, besides to know that when you see a doctor who knows enough about Parkinson's, they'll look for certain clues to make sure it's not one of these other conditions. So this is a picture of Aspen. It's a city in Colorado that one of the big courses happens where neurologists can learn about Parkinson's and other things. Beautiful place. So let's talk about atypical Parkinsonism. One condition is called, I'm only going to just introduce these briefly so you've heard of them in case they ever become relevant to you. Multiple system atrophy looks like Parkinson's on the outside, but it seems to progress faster and it doesn't seem to respond to the medicine the same way. People might get a little benefit or not at all, or it works a little then stops working. It can be impossible in the beginning to tell the difference which one it is. But with time, when you get to see how it changes over time, it can help distinguish the two. We treat all these conditions the same way. If it's Parkinson's or one of these, the medicines we have to choose from are the same. So it's more just an issue of knowing what to expect than it changes what your doctor does for you. But people with this condition may have coordination problems, like trouble doing things with their arms with coordination, and they may have more of the problems with what I told you about the autonomic nervous system earlier in the course of the condition. There's another condition called progressive supernuclear palsy, or PSP. Dudley Moore had this condition, if anyone remembers, that actor. This one looks just like Parkinson's, but people could be falling and even needing a wheelchair within the first 2 years. That is very, very unlikely for Parkinson's. So if someone has very rapid progression over only 1 or 2 years, we think about this condition. And people with this condition have this interesting problem that when they tell their eyes to go up or down, they won't do it. So they tend to get double vision, and they may even have a change in their facial expression that almost looks facial expression. Also can develop problems with laughing when things aren't very funny or crying when they're not even that sad. We will call that pseudobulbar affect. You don't have to remember any of this. It's just kind of other things that actually share some of the same symptoms. The more we learn about those conditions, the more we're going to learn about Parkinson's. Okay, just a couple other ones. Corticobasal degeneration looks just like Parkinson's. It's asymmetric. One side is usually worse than the other, just like in Parkinson's. A lot more of the dystonia, a lot more jerky movements, which people in Parkinson's can have little jerks too, but in this condition they tend to have more. And they have more problems with areas of the brain other than that deep area I showed you, where they may have more problems with cognitive processing. And there's this really interesting thing that happens rarely in this condition called alien limb, where an arm can do stuff that you're not even telling it to do, like just float up by itself. And this really happens, and the arm may even grab stuff without you telling it to. So it sounds really hard to believe that happens, but I promise it really does. So that's an interesting condition. And the last two, one is called Lewy body disease. This one's interesting because it has Lewy bodies in the brain just like Parkinson's, but a whole lot more of them. And as a result, people have a lot more problems with dementia and hallucinations very early on. If those are experienced in the first couple years, again, it's much less likely that it's Parkinson's. It's more likely it may be this condition. And people with this condition have a lot of ups and downs within the day. Sometimes they could be bright and alert, and other times they seem to be spaced off or less responsive. And the last one people like to ask me about is called normal pressure hydrocephalus. It's a condition that has to do with the balance of fluid production. All our brains kind of hang out in this fluid called cerebrospinal fluid. We got hard skulls, and if we didn't have any fluid in there, every time we did this, our brain would go boing, 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 and it would bounce and bruise. So there's fluid. The brain is sort of soaking in this fluid, so when you move around, it just kind of floats and moves around. In this condition, the fluid balance gets out of whack, and there's a pressure from all that fluid. That's called hydrocephalus. And it puts pressure on the pathways that carry movement and walking, and people develop shuffling and stiffness, cognitive problems, and even incontinence. But they can look on the outside like someone with Parkinson's. So sometimes a scan may be done to look for this because it has a different treatment. It doesn't get better with the Parkinson medicine, and it may require even a surgical procedure to drain the fluid. This is so rare. And usually the walking pattern is just a little different that most neurologists who see lots of it know when to suspect this condition. Okay, so back to Parkinson's. The reason we're here today is not to focus on the mimics, but just to know there are other things that can overlap to make sure you have the right diagnosis. How does your doctor figure it out? Is there a blood test to say Parkinson's, yes or no? No, there is not. The real way it's diagnosed is what we call a clinical diagnosis. That means by what your doctor sees, or your nurse practitioner or PA when they examine you. So it's not a blood test, it's how you look, what you describe, and what happens when you take the medicine that's supposed to help you when you have Parkinson's. And basically, sometimes we'll even give you a dose of levodopa when a person first describes the symptoms, just to see if it helps or not. We're not talking about does the medicine give you the benefit you're hoping for after 20 years, but really in the beginning it really should be a dramatic benefit. MRI is not necessarily needed, and usually we don't do it unless we have reason to suspect it could be something else. So if you had a really sudden change overnight, we might worry that you had a stroke. Or if you had some suspicious things when we examine you, you're paralyzed on one side, and we go, uh-oh, maybe this was a stroke or multiple strokes and not Parkinson's. But usually we don't have to order any tests at all. There are some interesting kinds of tests that give you special tracers that go to those dopamine areas in the brain and look different if you have Parkinson's or not. So if knowing 100% is super important to you, your doctor may order one of these tests. Typically we don't need to unless there's just something that's not quite definite and we need to confirm it. One of these is a PET scan that gives a tracer called 18-fluorolevodopa that goes to dopamine terminals. And the other is called a DAT scan, which uses SPECT imaging, a different kind of scan. It's not an MRI, but you still lay in a tube kind of like an MRI. And it gives this sort of tracer that's linked to iodine. It goes to this presynaptic dopamine transporter. The bottom line is it goes where the action is in Parkinson's, and it lights up different if you got it or if you don't. This is what it looks like. And on the left, you can see this bright area. Maybe you can see it. It might be hard in the back of the room. But on the right, it looks duller because there are less of those dopamine neurons to soak up that tracer that was injected. So it will look less bright. This is kind of iffy. You can see that, wow, I'm not sure I can see how bright it is, or how do you know if it's borderline? And it is tough to interpret these tests. We only use them when we feel like we know one way or the other and we need confirmation. Unfortunately, this test doesn't distinguish those other ones I told you about that mimic Parkinson's, that we call atypical Parkinsonism. It doesn't separate those from Parkinson's. It looks abnormal either way. It's more helpful to know it's not due to a drug and it's not due to essential tremor. Okay, so I'm going to tell you some interesting things. We already went through the symptoms. We already went through what's going on under the microscope. We already went through what else does it do besides tremor. So that's the basis of understanding Parkinson's that we'll talk about today. But I want to tell you two interesting things I thought you might enjoy hearing about. And these are things that some of my patients have heard on the media and asked me about. Some people have asked me, am I supposed to start drinking coffee? Because there's been this interesting thing about caffeine. Personally, I like caffeine a lot, and if I didn't drink my coffee this morning, I may not be keeping up as well as I'm talking to today. But interestingly, we're trying to figure out what causes this thing. I told you we still don't know. So the way we do that is you get a whole bunch of people that have it, and you ask them a whole bunch of questions and figure out what's unique to these people, or what do they have in common. Did they all grow up on a farm and they all had a lot of pesticides exposure? Did they all live in the same city and maybe there's some sort of toxin over there? Are they all the same nationality? What do they have in common that we could sort of put these clues together? And something interesting that came up was people who excuse me, people who had it were less likely to be caffeine drinkers. So that was kind of unusual. We couldn't understand why that would be. And so it looked like that coffee drinkers were at less risk. It doesn't mean there weren't plenty of coffee drinkers who got it, and plenty of people in the room say, I have it and I drank coffee all my life, a whole pot a day. But if you look at the numbers, there were more people who were coffee drinkers that had a little bit less chance of getting it. So we said, is this for real? Is this just coincidence? Sometimes if I ask all of you at the table, what's your favorite color? A few people have the same favorite color. It doesn't mean that they have anything else in common. It's just coincidence. So anyway, we looked to see into this, and basically, bigger studies were done where someone said, okay, I know you can't read this, so I'm going to tell you the important parts. Bigger studies were done where they said, in this small study, it looked like caffeine might be something. Well, let's look at all the studies that were ever done of caffeine and Parkinson's and put them all together. And it included over 900,000 patients were involved in different studies across the globe. And it was interesting because it came out again that people who were more tea drinkers or caffeine drinkers, the more they drank, the less their risk was of Parkinson's. And interestingly, coffee drinkers, when they drank more, they had a little bit less risk. But at some point, if you drink more and more, it doesn't help you any better. So after 3 cups a day, it didn't give them more benefit. The people who drank 4 cups weren't at less risk than the people who drank 2 or 3 cups. So then someone said, all right, well, if that's true, I'm not sure if it's true, but if it's true, if I already have Parkinson's, should I start drinking coffee every day? And it's not so clear. Basically, in a short study, it was only 6 weeks, and only 60 patients, so 30 of them drank coffee and 30 of them got sort of fake coffee or maybe decaf, placebo. And the people who drank the milligrams of caffeine was about the same as 2 or 4 cups of coffee a day. And they weren't any less enough. The caffeine wasn't able to overcome the sleepiness that people had, which is what we usually use caffeine for, is to help overcome sleepiness. But the people did score just a little bit better if they were drinking caffeine on things that we score when we look at Parkinson's. So the difference was not a lot, but there was a tiny little difference. So the tricky part is when we give people placebo in a study, it means that you don't know if you're on it or not. That way anything you report is really what you're experiencing. If I tell you I'm going to give you this magic pill, it kind of makes your brain trick you into saying, I think I might be better. Wait, maybe I'm a little better today, because you're aware that you got something. So they give people placebo to say they don't know what they got, so they'll really just say what they're feeling without any expectation. you can't really give someone placebo with coffee because you can kind of feel it if you got it or not. When you drink coffee, you may have symptoms. So people may know they got it and they might say they feel a little better. And also there's an issue with caffeine that you get tolerance to it. When you keep drinking it every day, you get used to it. So for instance, I drink coffee every morning. If I drink 2 cups today, it doesn't really affect me much. Whereas if I skipped it for a whole month and I drank a cup, I'd probably feel really wired. So this benefit might attenuate. So that was said, well, we know it's probably not coffee that helped the people not get Parkinson's. It's probably something that's associated with coffee. So scientists did a bunch of stuff and figured out what coffee stimulates in the brain are these adenosine A2A receptors. So basically they said, what's it doing in the brain? Well, it's going to these receptors that live to the same places where dopamine receptors live. Wow, isn't that interesting? So it's going somewhere that's kind of close to where the dopamine's going, and maybe there's something that we can do to stimulate those receptors that actually affects dopamine receptors. So all I'm telling you about this for is not that there's any use to drinking a whole bunch of coffee. I'm telling you that this is how science works. You do these surveys and questionnaires and you figure clues, and then that clue took to the next step, which was that maybe these A2A receptors are useful. So now all I want you to see is a bunch of words that tell you there's a bunch of research going on different A2A medicines. People always want to know, well, what else is there besides all these medicines we already have? And now they're looking for medicines that aren't even dopamine medicines, but that help the dopamine function in different directions. And there are at least 3 different compounds that have been looked at. They all seem to help in the beginning, but in bigger trials, they didn't show enough of an impact that the FDA approved any of them. One of them is already in use in Japan. But it's exciting to know that different new novel therapies are being looked at. Another interesting one that people ask me about is that they've read that smokers may be less likely to get Parkinson's. Does that mean we should smoke? Well, of course not, because then we can get lung cancer and other bad things, heart attacks, strokes. But in those big studies of asking people with Parkinson's what do they have in common, it also came up they were more likely to be non-smokers. So somebody did a study to say, hey, would smoking or nicotine patches help my Cinemet work better? And they actually took people who didn't have Parkinson's and they showed that nicotine actually made it less effective. It made it 34 to 60% less effective. So I hold to this symbol which says don't smoke. It does not help you. Okay, so that's kind of the end of just understanding Parkinson's disease before medicines. Does anyone have any questions? So the question was, is there any research about diet in Parkinson's? And basically in Parkinson's, eating just a well-balanced, healthy diet, the same that's recommended for everyone for good health, is the main recommendation. There's not a specific food that influences Parkinson's. One influence that is relevant, though, is the timing of food related to your medications may have an important impact. So basically, the places in your belly that absorb the levodopa when a person swallows it or the other medicines also are the places that absorb protein when you eat a nice juicy steak. So if your belly has a nice steak floating around and a few little pills floating around, less of the medicine may be absorbed than if you took it on an empty stomach. For most people, taking your medicine with food works just fine, and you get enough that you still get the same benefit. But for some people, especially if you have it long enough that it's really important to absorb every little drop you can, taking it on an empty stomach can help. So taking the medicine half an hour before meals or 2 hours after. But usually that's only necessary for some people. So timing of medicine and amount of protein can influence the absorption, but there's not a certain food you have to eat or shouldn't eat.
Hi, I have a question about the Centers of Excellence for Parkinson's disease you mentioned. Are those listed someplace?
That is a great question. The question was, I alluded to Centers of Excellence, and I showed a slide about surveys at Centers of Excellence. And actually, I would encourage everyone to look into that. There is a website, the National Parkinson Foundation website. Pete, is it parkinson.org? www.parkinson, no S, just parkinson.org is a website. It's a fantastic website. It's my favorite website to send people to from the National Parkinson Foundation. It has links. That means you can click on stuff and learn stuff. It's got a link to something that says for patients, PD 101. And there's a bunch of questions, more than you can read in one setting, that talk about different stuff you're wondering about. Maybe you forgot to ask your doctor or you're embarrassed. There's an ask the doctor portion where people post questions like, I'm kind of embarrassed to ask about this constipation issue or sexual issues. Somebody asked about it before you. I promise you, if you're thinking it, someone else has thought it, and it's probably posted as a question. One of my colleagues, Michael Oken, does a column of what's hot in Parkinson's, and once a month he updates it with something interesting that month, something new that's been looked at. And yes, you can find centers of excellence on that website. In fact, there's a little search window. I think it's on the upper right-hand corner. If you type, this is how I do it. Somebody tells me, hey doc, I'm moving to Indiana. Do you know anybody there? And I may or I may not. And I'll go in that upper right-hand corner and type Centers of Excellence, and it will bring up a listing state by state of the Center of Excellence in your state. I think you can even search by your zip code and find the closest one. And basically, places that do a lot of Parkinson care may apply for that designation, and the National Parkinson Foundation takes a lot of pride in that. They actually will go visit the center, tour the facility, see how easy it is for patients, interview people, make them fill out paperwork about, tell me exactly how many people you take care of, tell me exactly what kind of physical therapist you have, tell me exactly whether you do surgeries and how many do you do and how good are your outcomes. They ask all these things. So usually if you're moving somewhere, or maybe you just want to know if you need a second opinion. Maybe you like your doctor, you're getting good care, but you just want to maybe once a year or twice a year kind of know that there's nothing new that you could benefit from. You may want to know one in your area to visit, and that's the best place to find it. Or if you're not really into the internet, or you don't even have a computer, you don't like to use it if you have it, there's an 800 number. Before we finish, I hope Pete will share this 800 number. You can call for free 24 hours and ask any question about Parkinson's.
It's not 24 hours.
Oh, I lied. Okay. I thought it was 24 hours. But anyway, it's every day it's there. It's free. You can hide in your living room and ask a question to someone on the other end of the phone. If they don't know the answer, they'll look for it. So that's another service that they offer.
Can I add something on that?
Yeah. Let me just repeat what Pete said, because some people in the front of the room are looking around like, I know I don't hear him. Do you hear him? He said that not only does that website give you centers of excellence, but it actually lists good movement disorder specialists that are not at a center of excellence, because sometimes the closest center is too far away. So it's actually just got a list of providers that are movement disorder specialists. He also mentioned that the 800 number will be in one of his slides later today, but it's 1-800-4PD-INFO. 1-800, the number 4, and then PDINFO, info, if you see the numbers on your phone.
Out in the, we have, what's the newspaper thing that they put out?
The newsletter?
What do y'all, Pete, what's the newspaper? I got a
Parkinson
report. There's a couple copies out there, and that's, when we're talking about Dr. Oken has a article in it, but that's a good resource. What we had originally tried to do was, and we might have to do this, is have people write their questions down, and we will pick those up. She can read them and then answer them, because this doesn't seem to be working.
That's a good idea.
Can anybody? We have one here.
Okay.
So write it down, and I'll come get your
Okay, I'll answer this one, and then I'll probably save the treatment medicine questions, because we're going to talk about medicines in more detail. But this particular question was, if I experience nausea after taking carbidopa, levodopa, if I throw up 20 to 30 minutes after taking it, do I need more? I do wait an hour after I eat before I take it. So, of course, I'll do my best to answer any questions that come up about an individual's symptoms, but of course, you know, your doctor should work with you specifically, because there may be other things going on. For a piece of paper, I can't know that there's not really an issue in the belly, like an ulcer. But assuming it's just the medicine, and every time this person takes it, it makes them ill, there are definitely ways around it. One is go ahead and take it with food. Yes, even if you absorb 5% less or 10% less, take it with food, because if you vomit it out, you don't absorb any of it. So taking it with food can help nausea. That's the easiest. The next thing is, well, fine, I took it with food and I'm still nauseous. Now what? Well, there are things we can add. If you notice that Sinemet is carbidopa, levodopa, or some people will say carbo, levo, or call it different things. It's two things in one. Levodopa is the good stuff. It is a precursor to dopamine. Your brain takes that, your body takes it, and turns it into dopamine. So it's kind of filling in the gap of what's missing. The carbidopa just comes along for the ride so you don't get sick to your stomach. On a very technical level, for the scientists in the room, it inhibits an enzyme that breaks down levodopa in your belly, and it stimulates receptors that make you nauseous. So when you take that, it prevents that metabolism, and it goes into the brain and actually becomes dopamine in the brain instead of in the belly. Syn-emet comes from the roots without, so they called it syn-emet when they added. First discovery was that, oh my gosh, we can give levodopa and people can get better. But unfortunately, they're sick to their stomach and vomiting. Well, then they figured out if we add carbidopa, they can actually tolerate it, and that's why it's called syn-emet, without emesis, without vomiting. Okay, let's just take a few. Okay, so one question is, can a symptom be shaking or tremor in the head? And the answer is yes. There are other things that are even more likely to make the head shake. One of them is called essential tremor, and one of them is dystonia. People who have dystonia without Parkinson's often will have a side-to-side head tremor. But yes, Parkinson's can cause anything to shake, the head, the arms, the legs. So the short answer is yes. And the next question is, what are your thoughts on closed head injuries causing Parkinson's? Example, explosions, boxers, etc. Your brain does not like to be beat up. It doesn't like explosions. It doesn't like external force to be applied. Anything that injures the brain, whether it's external trauma or whether it's strokes that cause a loss of blood supply to certain areas, you can experience symptoms of dysfunction of that particular area. So you can get symptoms that look like Parkinson's due to certain strokes, due to recurrent trauma to the brain over and over again, due to medicines that are toxic to those areas of the brain. Even certain drugs could cause, meaning illicit drugs, can also cause Parkinson-like syndrome. In fact, some of the best discoveries in Parkinson's came because all these young people started showing up in emergency rooms with Parkinson's overnight and saying, you know, it didn't make sense. What the heck is going on? Is this a new virus? And what it turned out is they were making drugs in the garage. Maybe not literally, but it was a designer drug. And it turned out that that amphetamine metabolite, or the metabolite called MPTP, that drug they were producing accidentally was killing off neurons in that same area that causes Parkinson's. And this was a huge discovery because we said, this isn't right. What happened to these young people? And it was discovered what they took. And then they said, well, what does what they took do to the brain? Oh my goodness, it's an insult to this area of the brain. Maybe this area of the brain is important in Parkinson's. And they use that drug to give Parkinson-like conditions to monkeys or animals so they can develop new drugs. So actually, yes, closed head injury, recurrent over and over again. Now, one car accident is not going to make a person usually look like Parkinson's, but boxers that have recurrent trauma can develop Parkinson-like symptoms. Okay, so we talked about this one. This question says, can I have my primary doctor make an appointment to see you? I don't know if that means can you send your doctor to me or can you come? But both answers are yes, I would love to see you. I'm happy to talk to anyone afterwards. I'm in Gainesville, Florida, at the University of Florida. And yes, actually there's, we're not here to talk about a very specific center. Everyone should be getting taken care of by someone with a lot of experience with Parkinson's. And oftentimes, there are some primary docs that take care of a lot of Parkinson's and are good at it. There are some general neurologists that are good at it. And there are some who don't take care of enough to know all the tricky things that aren't obvious about Parkinson's. And in that case, which is usually the case, it's good to have a movement disorder specialist. I'm personally at University of Florida. There is a website, if you search University of Florida movement disorders, that you can link and make an appointment, or your doctor can fax referrals to me or any other movement disorder specialist. I have to, my personal website, I can find it for you and give it to you, but I usually Google UF Movement Disorder Center for University of Florida Movement Disorder Center, and that's how I personally find it, but I'll look it up and I'll tell you what it is. Okay. Okay, is there a specific exercise How often do you do it? Why is riding a bike good for you? So I'll tell you my best answer. My best answer is get moving. I don't care what exercise you do, but it should get your heart rate going. You should break a little sweat, and you should feel like it's a little harder to have a casual conversation. So bicycle riding is great because it's less impactful on the joints, and many people may also have some arthritis or pains. Walking is great if you're not a runner. Dancing is great. There's a lot of different things that are good. And actually, there's a lot of research coming out that exercise helps people who have mild cognitive impairment not get demented or not get demented as quickly. So it's good for your memory, it's good for your heart, it's good for your muscles, and it's good for your Parkinson's. And there's a lot of research coming out that people who exercise have slower progression. Anyone who takes care of a bunch of people with Parkinson's will tell you, I see it, I don't know why, but I know that it helps. I don't feel like there's one specific exercise, but there is some research about bicycling. This asks about bicycling, why would it be good? In Parkinson's, it's more difficult to initiate movement than it is to continue movement. I'm sure someone's nodding in this room like, oh yes, once he gets going, or once I get going, or once she gets going, she's good to go. But first getting up and moving. When you exercise, there's this extrinsic force that helps you keep bicycling, when you bicycle. So that little bit of repetitive movement seems to be helpful, but that's not the only thing you can do that's good.
Two more, that's it.
Okay. Is multiple systems atrophy also a dopamine deficit disease? And it is. It is a condition that has a dopamine deficit. It does tend to gain some mild symptomatic benefit at times from replacing dopamine, but we know that it's more complex, and it seems to be more diffuse than just the dopamine issue. Okay, this question I'm not totally sure I understand, but I think that it probably is more for the next section. And it just says 2 new drugs coming out next year, what will they do? I'm not sure which the drugs are being referred to, but I will talk about some new things that are being looked at. So I'm going to save that one. And it says brain implants, and we'll talk about that in the next section too.